All right, good afternoon, everyone. Thank you for joining us for session 2 of the ShotSmarts 2022 Immunization Conference. First off, I want to thank some of our partners who have been with us for many, many years. Next, I'd like to just go through some housekeeping items. So first, this call is being recorded. If you disagree, you may disconnect now. Slides and recordings will be posted on our website after the conference. Please make sure you're muted unless you're asking a question. To ask a question, please raise your hand, use the raise hand function, and Megan will call your name for you to ask your question. When your question is complete, please remember to put down your hand. You may also submit a question into the chat box, and I will read those out loud at the end of the session. Also, please consider keeping your camera off unless you're speaking, so we can make sure the bandwidth keeps the presentation and all our voices nice and clear. And now, I am going to stop sharing and give presenter access to Dr. Hahn as I introduce her. So Dr. Hahn attended medical school at Michigan State University and completed a residency in internal medicine at the Mayo Clinic's Graduate School of Medicine, then completed a fellowship in infectious diseases at Duke University Medical Center. She serves as the medical director and state epidemiologist for the Idaho Division of Public Health and is a liaison member to the CDC's Advisory Committee on Immunization Practices. Thank you for joining us this year, Dr. Hahn.
Thank you. Well, welcome everybody. I'm going to try to keep this well under an hour so we have time for questions and answers. And I'm going to start with COVID because it's obviously still on everyone's mind. There's still a lot going on, a lot of changes happening. But I saved lots of time to talk about some of the other vaccine preventable diseases and just kind of talk a little bit about what's happened to them in the last few years and what and how our vaccines going in that area as well. Start off again, as I mentioned, we'll start off with COVID. So as many of you are aware, the Idaho State Public Health Emergency actually ended last Friday. And this has some implications for things like hospitals and other healthcare entities that have had some extra help with staffing, and it also impacts other areas as far as kind of responding to COVID. But you may be aware that the federal designation of a public health emergency has been renewed. So we're in this kind of odd situation where we're in a federal state of emergency, but not a state public health emergency. So some assistance, grant funding, and other things that are very helpful continue through that federal declaration. And of course, as many of you are aware, we've been very fortunate in the United States in that the last several months, the disease rates have gone down dramatically, but you'll notice that tiny little bit of an uptick here in the last few weeks. And if you look at that a little more closely, what you see here, and can you see my arrow as I, Marin, could I ask you, can you guys see my little arrow as I move around? Oh, super. Okay, good. I love using that. Okay, so as you can see here, there's some real increases, and these are states up in the Northeast. For this graph, I picked Massachusetts, New Jersey, and New York State. And you can see as a contrast here, for example, Colorado and Idaho, where disease rates remain low. Looking at that a little in a different way, you can see here the new cases per 100,000. This is the most recent graph we have from the CDC, or the map, I should say, showing through mid last week. And you can see here that case counts really are rising in the Northeast. There are other scattered little spots throughout the country, but this is really where it's most concentrated, and especially if you look back, compared this to a month ago, we actually in Idaho are doing better than we were a month ago as far as our cases, and so is much of the Midwest. But the Northeast has actually seen a return of increasing case rates. How severe that gets, we just don't know. Of course, we attribute this to that BA2 subvariant of Omicron that is starting to increase, and particularly has increased the most in the Northeast, but we don't know exactly how it's going to impact us yet. In the meanwhile, for now, case counts in Idaho remain very low, and we have not seen an uptick yet. We are, of course, watching this every day, and won't be surprised if we do see a little bit of an uptick as BA2 continues to spread. In the meanwhile, as far as the CDC recommendations based on community levels, we are, the entire state of Idaho right now is at a low community level of COVID, and community levels are determined, as you can see in that little table there on the right. We're considered low because we have fewer than 200 cases in the last 7 days per 100,000 population, and we also have very few hospital admissions. So you add those two together, and that puts us in the low transmission risk category. So we're really pleased with that, of course. On the other hand, those of you that might work in healthcare settings may continue to look at the transmission levels. A little confusing to have these two different maps that we need to refer to, but you'll notice that this is a little bit of a different criteria of what CDC is using for this. Transmission levels, you have a stricter criteria here. Remember the other map, you just had to be under 200 cases per 100,000. Now to be in the low transmission risk, you had to be even lower, of fewer than 10 cases per 100,000. And then the other marker here is based on percent positivity of testing, PCR tests. So it's a different measure. It intended to be a little tighter, a little stricter, because this is for healthcare settings and determines what type of PPE and some other recommendations that healthcare settings need to be aware of. So you'll notice here, again, throughout the country, again, we see the same picture of higher transmission in the Northeast, and also interestingly in Alaska and Hawaii and Puerto Rico. But closer to home here, we are still at low or moderate transmission levels in almost all of our counties. But just in case you, I think there's a lot of confusion in the public about this. I'll hear the media referring to that the community levels have replaced transmission levels, but that's not entirely true. Transmission levels are still important for hospitals to look at in other healthcare settings. So just so you're aware, there are both things going on. So how is the United States done with, I'm going to switch now to just a vaccination, kind of talking about the COVID vaccines. And you can see here, this is from the website, Our World in Data, where they try to take the best data they can from countries around the world. And you can see here, as far as COVID vaccinations overall, we're sitting among these countries with good quality data that they're able to compare. We're kind of middle of the pack. There are certainly countries with higher vaccination rates, but a significant number of countries with, of course, much lower vaccination rates, especially on the African continent, with some countries with very low vaccination rates at this point. And of course, this is differs by age group. We'll look at some Idaho-specific data next in a little bit, but you can see here that in the United States, the seniors, and I'm very glad to see this because, as we all know, these are the folks at the highest risk. If you look at age group alone, it is the seniors who are at the highest risk of severe outcomes, hospitalizations, and death from COVID. And they've, first, of course, they were eligible first. They were the first age group to be specifically recommended and allowed, if you will, kind of first in line to get the vaccine, and the rates immediately shot up quickly and have kind of flattened out, but continue to increase slightly over time. And then as you look here at the younger age groups, you can see that the rates also immediately shot up and kind of flattened out. Disappointingly, however, you can see here as we got down into lower populations, less and less of that sort of steep increase. And in particular, most recently, of course, 5 to 11-year-olds were only recently recommended to get it, but we see it already flattening out at maybe approaching 30% in this age group. So we definitely have a lower rate and a lower rate of increase in this population right now. What about overall, how did Idaho do with vaccinations? And this is looking at fully vaccinated kids and adults, anybody age 5 years and older. And the highest rate states are mostly in the Northeast, with Rhode Island, Puerto Rico, of course, down here, Hawaii down here, but the other states are mostly out here, Massachusetts, New York, Maryland, of over 80% vaccination rates, whereas the lowest is Alabama, and Idaho is not at the lowest, but certainly in the lower end of things as far as our overall vaccination rates. And within Idaho, it varies by county. If you look closely, you'll see here that Blaine County really stands out as having had one of our highest vaccination rates. Really from the beginning, we all remember how Blaine County got hit early and hard by the pandemic. They were first county to have really big outbreak, and I don't know if that's one of the reasons why vaccination was uptick was so immediate and strong. Whoopsie, sorry, I just made myself go backwards on that. But that they remain by far the highest vaccinated county, followed by Ada County. You can see here quite some variation throughout the state, just showing this for your awareness, depending on where you live, the rates certainly. And this is from our website, for those that aren't familiar, so I'll use a chance to mention the website. You can look at this any which way you like, including how many folks have had a booster dose, how many folks have had one dose of the 2-dose series, and how many are fully vaccinated. You can look at it by public health district as well. I urge you to go look at that website in more detail. So this is how we're doing more recently in Idaho. If you start back to when vaccine first became available, of course, dose 1 and 2 is what was initially administered, a big peak there, and as that started to decrease, we saw another surge of disease starting in July 2021, and rates started to go up again as the Delta variant came into the state. And then as boosters became recommended, a lot of our vaccination really since then has been the booster dose, and most recently, I'll point out here the second booster, or what we're calling for purposes of our analysis, these are people who've had 4 doses of vaccine. These people would almost all certainly be getting a second booster after having the primary series with an mRNA vaccine. But these are the total doses. We've seen a little bump. You'll notice, though, that we have very few people still initiating a vaccination, that has continued to be fairly low. And in particular, again, to highlight the younger children, 5 to 11-year-olds that are recommended to get vaccine, you can see there that initially some enthusiasm when this was first brought out for this age group, recommendations for this age group were made, and you can see here that gradually over time that has tapered off, even though, as you saw earlier, really only about 30% of our kids are vaccinated in this age group, but we have very few vaccines being given in this age group, relatively speaking, at this time. So what's going on with COVID boosters? I'm sure many of you are familiar with on the right, I have the current recommendations other than the newest one. This is still up on CDC's website. They haven't updated this yet to show that second booster recommendation, but this is a good site to look at for who should be getting that first booster. And then, I can see they do have this here. Okay, who can get a second booster? They have tucked into here. So you can see here that they do have that included. Sorry, I didn't notice that when I first pasted this up here. Who can get a second booster? Adults 50 years and older. And then for Janssen also, this is a little bit confusing. If you have patients that received the Janssen vaccine initially, the recommendations are a little more complicated, but I do think it's important to note that for people that initiated with the Janssen, it's really now a strong recommendation to get an mRNA vaccine for further vaccination. And in fact, for the booster, that second booster really it must be an mRNA vaccine. The Janssen is not authorized for that dose. So while the Janssen vaccine has some good efficacy, it's not a bad vaccine. The protection is definitely greater for folks that then go on for their boosters and get one of the mRNA vaccines. And I think Marin will be sending out these slides after my talk or making them available, and all the links to these sites and stuff are in those, will be in that handout. If you're not aware of how to find any of this information, that'll all be available. So here's the latest recommendation, that second booster that I referred to earlier, and of course has caused quite a bit of I'd say confusion and differing opinions about this. So just in brief, the second booster is for at least 4 months after the first booster dose, and this is now a may get the second dose includes people 50 years old and older, anyone 12 years old and older who are moderately or severely immune compromised, and adults who haven't gotten any mRNA yet, basically. So the idea is if you got Janssen, even if you were boosted, you should get this second booster with an mRNA vaccine. So this is a graphic from CDC that I think is fairly helpful in simplifying the recommendation. So what's happening with the boosters right now is that there is a meeting. First of all, there was a meeting. I say next steps, and then I realized that already happened. So the FDA's Vaccine Advisory Committee met in April. A couple screenshots from there for your interest, to discuss an approach for boosters. Everybody realized that it's a little bit hodgepodge right now. It appears to be driven by the manufacturers, and meaning they are looking at the data and they're saying, wow, we think we need to develop another booster, we need to develop a vaccine specific for this new variant coming out. So they're sort of doing their own thing. And so I think the FDA and now the CDC are trying to corral this a little bit and say, should there be an increased federal role in the strategy to really help determine what should be the frequency of boosters, what new vaccines should be developed when we see a new variant coming along. Is there really going to be significant better protection with a specific vaccine for that variant, or should we continue to use the vaccines that have been out there already? In addition, for this FDA meeting, they talked specifically about this question, which is, look, we really already have a model for, potentially have a model for this, which is the flu shots, which every year, as you may know, in January, the WHO convenes a meeting in January and says, okay, what have we been seeing in the Southern Hemisphere? And world experts gather together and they determine what strains will go into next year's vaccine shot. And then the FDA meets in March usually to say, is that what we want to use in the United States? Are we going to follow the WHO recommendation, or are we going to tweak it? Usually it's very similar or the exact same vaccine. So there's a lot of work that's gone into developing this model. So should we be looking at how flu works and trying to do something similar for COVID? So at the FDA, and there was a lengthy meeting, several hours, but I thought this slide would be most helpful to just kind of highlight that unfortunately SARS isn't behaving as nicely as flu at this point. We can't yet predict those variants. We don't have a Southern Hemisphere, if you will, to look at and say that's what's happening there, so this is what's going to come to the United States next. Sometimes we see a variant that we get worried about. You remember there were variants from Brazil, there were variants from other places that have not spread. Sometimes they have, but not always. So we just don't know how to predict yet. And then there are vaccines, COVID vaccines, that are already in development, or they're already authorized, or they're already even licensed. How do we make sense of all that, working with the manufacturers who are already moving ahead, evaluating vaccines that have this updated composition, and they have clinical trials ongoing. So how do we don't want to disrupt that process if they have vaccines that are underway that might be great, effective vaccines. So, but there's no coordination right now, and the time needed to manufacture new vaccines might depend on the type of vaccine, the facilities, et cetera. One thing we've really learned with the mRNA vaccines, and one thing we've heard, is that it's really quick for them to develop new variant vaccines. But this is still a relatively new technology, and we definitely want these new vaccines to go through safety trials and vetting before they're rolled out. So in the end, this lengthy meeting on earlier this month, I thought these were the most telling. Nothing was resolved from the meeting, and 2 committee members spoke to the media and really said, well, this was a good opportunity to show how complicated it's going to be. And Dr. Offit, who's also on that committee, some of you may know his name. He's just a vocal vaccine proponent and speaker. He's been in Idaho a few times to speak at some of our immunization conferences, so you may have heard him there. He's a pediatrician at Children's Hospital of Philadelphia. And he always says things well. And he just basically said, right now the companies are dictating the conversation, and the companies are moving forward with the different vaccines, and it shouldn't come from them. It should come from really us, meaning the FDA or the CDC. There should be more of a coordinated approach here. So bottom line, they tried to come together to come up to look at the flu model, and they felt like there's no way they're going to be able to make that work, at least for this fall. It's too late. This is a good conversation moving forward, but for right now, we're not ready to have. So you guys probably get the same question I do all the time. How often are we going to need to have these boosters, and are they going to ever just get it so we get a once-a-year shot like flu, or obviously ideally not need any more boosters because we have a vaccine that has long-lasting protection? And the short answer to that is we just don't know yet. But we're definitely not there to the point where we're going to be able to reassure patients that, yep, we're going to be able to move into an annual booster, or even we've got vaccines that are going to provide long-term protection that you won't need any type of booster, even if we had a big surge of disease come through. So to kind of wrap up my COVID piece, now we're really at next steps, which is that this week, in fact, tomorrow, the CDC's advisory committee is meeting to talk about boosters. I think that's a meeting I participate in, and I think we'll face the same challenges that the FDA did. There's no real answers yet, but I think one thing that CDC would like us to focus on at that discussion tomorrow is how do we make the current recommendations for the 2 boosters make more sense to people, make it more clear to people, clarify between you may get a second booster versus you really should now versus you might be able to wait. We need to make this more clear. I think there's a lot of understanding that there's just a lot of confusion, not just among patients, like people aren't smart enough to figure out. The messages are conflicting, the messages are confusing, and they need to get more clear. Secondly, you may have seen this headline that Pfizer announced that they have data showing a good immune response in kids 5 through 11 when given a booster. It doesn't mean that those kids need a booster, and it doesn't actually even show protection. It just shows a good immune response. So it really is helping demonstrate safety, and that there's expected efficacy of a booster should let's say another surge continue, but right now that is not a recommended dose for that age group. But again, this kind of goes back to my earlier point that the manufacturers are moving forward with some of this work, and probably rightly so. It's good to have this knowledge there, but just adds to the confusion about, so should 5 to 11-year-olds get boosters? Again, that is not a recommendation right now, but Pfizer is working on it. And then lastly, as you can see at the bottom of my slide, of course, we're all waiting to see if vaccines will be approved for kids under 5. Very confusing for everybody. I won't rehash it all. I'm sure you guys remember the conflicting headlines. FDA announcing they might try to approve these, and then that was withdrawn after some concerns about that being too preliminary, and that it was very harmful to try to rush this important process in children without having all the data in front of the FDA. So we are still waiting to see if those doses will be authorized for children. Remember, Pfizer looked at 2 to 5-year-olds, and then also 6 months to 2-year-olds as separate populations. So you could see one of those 2 groups being authorized, or both. Hopefully it is able to be harmonized, because that we don't want to add any confusion. Moderna, meanwhile, has been studying the 6-month to under 6 years of age group. So you'll notice a slightly different age group there. And we're hopeful later this spring that we might hear more about one of those moving to FDA for authorization, but that is not clear yet. Okay, I'm gonna leave COVID for right now, and talk about just some of our other just refreshing change of pace. Let's talk about what else. And I wanted to specifically focus on these vaccine preventable diseases because we have good data on them. Pertussis. What happened to pertussis? What happened to meningococcal disease, which you may remember is spread by respiratory droplets, and so you think might be impacted by us all wearing masks or not going to school or to work, that type of thing. And then, of course, influenza and other respiratory disease. I have a quick note about RSV. So pertussis, whooping cough. Those of you that have been in health field or public health for a long time might recall that Idaho has had some very large outbreaks of pertussis in years past. The most recent one of those was in 1997. That was extraordinarily a big outbreak, but we continue to see outbreaks of pertussis every several years. Of course, it's a vaccine preventable disease, but not as preventable as some of our other ones. You can have fully vaccinated children that still do get pertussis, and so we continue to see some cases every year. But interestingly, if you look in 2020, maybe certainly a decrease from the last couple of years, but nothing too remarkable. But 2021 in particular, only 5 cases were reported in the state. Remember, when we see decreases like this during a pandemic, there's many things that can be happening here. It could be that parents of children who are coughing might rush them in to get a COVID test, and if that's negative, think, oh, thank goodness it's not COVID, and have them at home. But maybe they're not being as tested. Some of the other respiratory infections like pertussis aren't being looked for. It is also possible that because of masking, social distancing, some kids doing online school, etc., that there is a true reduction in transmission of this disease. You have other things that can play a role. Healthcare systems are overwhelmed, so kids aren't being able to see as quickly, or they aren't being test labs are overwhelmed and they're not able to do as much testing. So you have a lot of things happening at the same time. So we can't say for sure, but there is a lot of supporting evidence that this is a real decrease. And I'll show you a couple data points here. So this is the CDC data. And you can see here what I just showed you for Idaho was definitely seen nationwide. Again, some of the same factors and considerations in as well. And this, I thought this was very interesting. This is from the United Kingdom, from England, and you can see here they saw a even almost more dramatic drop off here as far as number of cases of pertussis in England. Altogether, reading the different studies that have been done on pertussis, most researchers believe that this was a real interruption of transmission, probably because of social distancing and masking, with some element of potentially of underdiagnosis of real disease. But again, a lot of studies still going on to try to sort this out. But it looks like pertussis, that some of the behaviors that were recommended to interrupt transmission of COVID probably had a big impact on pertussis transmission. So let's look at meningococcal disease. Again, here, a little less dramatic, thankfully. Invasive meningococcal disease, or what most people would just call meningitis, but we know is really specific meningococcal meningitis or sepsis, that is fairly rare in Idaho, thankfully, and really has come down over really many years, and partly certainly due to the implementation of routine vaccination. But you'll see here we certainly had we only had 1 case reported in both 2020 and 2021. So it'd be hard for us to make some hard conclusions here. However, if you look at the United States data, again, you look at 2020 and 2021 compared to the trends over the 5 years previous, and it does look like there was a real decrease in meningococcal disease in those past 2 years. So that is encouraging news. Obviously a very severe and unfortunate disease that can impact young people and all people quite severely, and good to see a decline. Again, probably due to masking, social distancing, and other measures that would have reduced transmission. So what about influenza? The influenza is a little different. We don't count every case of flu. It's not a reportable disease. So we have to look at the data in a little different way. So this is one thing that Idaho, our Vital Statistics Department, puts together for us every year is during the flu season, how many deaths due to flu were reported. And you can see here going in 2018, a pretty severe year, over 100 deaths being reported due to flu. And you can see here, let's say the average would be anywhere from 20, 30, 40, up to 100 deaths reported in the flu season. What happened was the first year of the pandemic, some of you might remember, or you guys lived this reality, very, very low flu activity overall. We did have 5 total deaths reported that year due to influenza, despite, I would argue, probably a significant amount of testing. People that die due to flu, many of them, of course, are initially admitted to hospitals, not all of them. But a lot of those folks were tested for COVID and for flu, and we did see some co-infections actually in this group of the deaths due to flu. So very low. And then this last season that we're just wrapping up, or that just wrapped up, well, I can't say wrapped up yet, but that is still ongoing. We still see, we tend to be trending lower, but maybe looking a little bit more like a normal flu season. Again, whether that's because some of the social distancing and so forth has been relaxed, or the masking has been relaxed, we can't say for sure, but we definitely see a more normal looking flu season. Here's another way of looking at it, and this is national data, and this is looking at hospitalizations due to flu. And again, I'll point out those 2 years. This is the year where nationwide very little influenza activity was seen and very few hospitalizations. And then this is this current flu season that's just ending, and you can see here lower than normal for sure. And of course we were very grateful to see this. There was a lot of concern about COVID and flu really overwhelming hospitals, even more so than they were overwhelmed. But we were fortunate that flu, probably partly due to masking and social distancing, in addition to ongoing flu vaccination efforts, helped control that. The last slide I'll show you in this regard is pediatric deaths, always, of course, incredibly difficult. You can see here a marked reduction, only 1 death reported over that first winter, if you will, of COVID. And then this last year, 16, again, hasn't finished the season yet, but definitely a lot lower than what we've seen in years past. Last respiratory virus that I'll talk about here is RSV, and RSV is really interesting and unusual. Those of you that work in pediatric clinics or work with a lot of kids, you're well aware of when normal RSV season is, really towards the, we start seeing cases in November, December, and they peak out here in the early part of the year. This is, for those of you who aren't familiar with MMWR weeks, week 1 is essentially the first week of the year, and that's when we usually see a lot of RSV high levels through the first month or 2, and then drop back down. And what happened this last season, very oddly, this is not just Idaho, throughout the nation, started seeing cases much earlier than usual, peaking a lot earlier than usual, and then really declining during the time when it is usually rising. And again, not just seen in Idaho, seen really throughout the country. So what's not known yet is what we don't understand very well yet in general, I'll say, is how one respiratory pathogen affects another. So did COVID, what is it about the COVID, is it just behavioral changes, or are viruses actually competing for each other for space, if you will, in our respiratory tracts? And is COVID able to kind of outcompete RSV? and yet when people have recovered, or when COVID maybe dips, is RSV able to get a temporary foothold? A lot of work still to try to help understand this, but important and interesting observation, complicating, of course, RSV prevention efforts. Many of you know those are often seasonal, where unlike the flu vaccine, and passive immunity is given to babies, premature babies, and young kids with certain congenital conditions, and it's hard to know if we're going to have to change all our practices around that going forward. Okay, so what did so I'm going to wrap up so that we have plenty of time for questions, but the last piece I wanted to talk about was, so what happened to just our regular vaccination programs during the pandemic? There's a lot we still don't know, but we're starting to have a little bit of data, then a little bit of time to look at our data. You'll see we have work to do, but we certainly wanted to show you what we know so far. So first of all, worldwide, clear loss of ground on childhood vaccinations. And this is work was done by WHO working with UNICEF. And this is the key facts from their report on this issue. Global coverage for the routine childhood vaccinations declined significantly in 2020. And that amounts to about 23 million children under the age of 1 who didn't get all their basic shots. And you can see the same facts put out in several different ways. I won't read each one of them, but a lot of concern that some ground has been lost, and it's going to take a long time to catch the world up, basically. So there were some really interesting studies done on this and published on this, and basically what you can see here, this is a study published in Lancet Global Health, and I like this one showing the big dip worldwide, and this is looking at 170 countries. This is diphtheria-containing vaccines, and you can see here really March, April of 2020 was where we saw these big dips, but somewhat hearteningly, quick recovery, and same thing with the measles first dose administration that had dropped off. So that is good news, but as we'll talk about in a few other studies, I'll show you, what we really need to see is a rebound, right? All these kids that got missed, we really need to see, we need to continue to work to catch those kids up now. This is a nice study from JAMA. I'll show you a couple illustrations from this, but what they did is they said, let's look in the United States and see how well we did compared to previously. So they looked at routine vaccination rates by age group in 2020, and then how many kids are up to date. So you'll see the way I put these slides together, I've grouped our younger kids, so through 6 years of age, 2 of them together on this slide, because really they look very similar. A big dip as clinics were closed, parents were told to keep their kids home, and you can see that really the strongest compared to 2019, the blue line, you can see a big dip in 2020, but with a pretty good pretty quick and pretty good recovery. Still definitely lagging a little below as maybe parents continue to worry about bringing their kids in. Same thing here, big dip, some recovery, maybe a little bit lower than expected throughout the rest of the year. All right, so here for the older kids, I just want to point out that you have the big dip, and I don't think the recovery was as strong. This is a little bit, kind of just a general impression, but you can see here as we get into the back to school efforts that you often see in these teenagers in August, not as high a peak even by August, and we continue to see lags. So just a reminder that our teens are particularly maybe at risk of never getting caught up, if you will. They don't have as many visits scheduled. They don't get into the doctor as much as these younger kids, and I am concerned we're going to really struggle with the younger kids. So here's the conclusions of the study, and what they said was there were substantial and persistent disruptions to routine infant, childhood, and adolescent vaccine delivery. And then I thought this was a nice way of putting it, looking at infants, 74% of infants who were up to date by age 7 months in September 2020 compared to 81% a year earlier. And those a little bit older kiddos, 57% versus 61%. So we definitely have a way to go here, and you can see this illustrated here with these up-to-date proportions by month, where it was looking pretty good in February of 2020, and then obviously the drop-off for understandable reasons, but just highlighting the work we have to do. I wanted to show you this quick study last, I think, in this series because it includes specific Idaho data. Very cool. Our state was chosen because it was one of 10 states considered to have a very strong immunization registry. So I want to just kind of give a shout out to our registry. You can see some of the other states. We know what great public health systems many of these jurisdictions have, and I think it was really a nice shout out that Idaho was included. But what it showed in Idaho and all the other regions was a big dip in MMR administration, and you can see here they were looking at kids. For this one, they were looking more at older kids, how many of them were administered to them, and you'll see this one is MMR, and the next slide we'll look at HPV. But you can see the big dip. Idaho is that solid, dark solid line. We actually didn't dip as badly, if you will. This is looking compared to baseline, and baseline being 0 compared to the previous years. We dipped down, but not quite as severely as some of the other states, and then pretty good recovery. And again, here's our back to school spike. But what we really need to do is remember all these kids here that got missed and make sure we get them caught up. This slide looks at the HPV, so kind of the same question, but what about our adolescents? Again, you can see the big dip. Again, I think Idaho fared relatively well. The dip wasn't, compared to baseline, wasn't as severe. And you can see here's our fall, or back to school, and it's really heartening to see Idaho at the really kind of relatively doing well with a lot of recovery, but I'm sure we still have teenagers that got missed here. So in conclusion, they said every jurisdiction saw severe drops, and there was increase by June to September. However, none of the jurisdictions experienced increases sufficient to catch up the children who missed the vaccination. So we just need to keep working on that. So looking at our registry a little more, I'll just show you a couple data that our immunization program was able to provide to me just within the last few weeks. And I'll just kind of quickly go through these because it kind of makes the same point of the MMWR you just saw. Here's our normal distribution of DTaP for young kiddos, and you can see here we saw in April of 2020 the same thing we saw it nationally, and for MMR, and in 2021 we do see some recovery from that, but still, if you look at total distributions throughout the 12-month periods, we do seem to be a little lower than we had been in 2018 and 2019. What about administered? That was distributed vaccine. What about administered? You see the same pattern. Of course, the drop-off there with pretty good recovery. And what we want to see is even a kind of a rebound and a continued increase in these vaccinations. But it looks pretty good. For MMR, same thing. You see the dip there. And this, interestingly, is looking at how many of those kids are now that are 13 months of age or more, how many of them had their MMR vaccine. And you can see here a persistently low number of kids who are 13 months that have gotten that 1-year vaccine. And I do think that some of these kids, what we're hearing anecdotally from providers, and some of you in the audience, you may say, yep, that's exactly what we're doing. Those kids missed their 2-month shots, say, or they missed their 4-month shots, and basically the entire schedule has gotten kind of deferred down the road, if you will. So they're getting their 12-month shots, maybe not till they're 14 months or older. You know, our recommendation generally is to try to catch those kids up so they're back on schedule. But we understand that in busy offices, and parents may prefer to keep those vaccines spaced out the way that that they normally would. We know there are a lot of challenges, but we just want to highlight, we understand that there are still work to be done to get these kids all caught up. For HPV, same thing. You can see there, this is administered right out of our registry, and you can see here that spike that I showed you earlier. from last August. August 2020 and August 21, we're happy to see that, but we know, and you can see here early 2022 data even, we're worried that we're a little lower than we were, and we're concerned about trying to make sure we get those vaccinations done. So I'm going to wrap up with just a couple slides showing by county. We work closely with our data cancer registry to make these really nice maps. You may have seen them in years past. So these are these vaccine preventable diseases that are also related to cancer. So HPV, of course, related to not only cervical cancer, penile cancer, oral cancers, other kinds of cancer, and we they work with us to try to increase HPV vaccination. You can see clearly the differences by county. Some counties have very strong vaccination programs, and some are struggling a little more. This is looking at females, 13 to 17. Generally same patterns you can see in males. Males are catching up to females, I'll say that. I didn't have time to include this data, but it looks year by year like that gap is narrowing. Very happy to see that. Initially, the vaccination, of course, was promoted mostly towards females. In fact, was recommended only for females in the beginning, but the boys are starting to catch up, and we're very glad to see that. Again, we see differences by county. And lastly, we're really worried about overwhelmed hospitals not able to administer hepatitis B birth doses. We're going to do some more work on this issue and just kind of make sure we haven't lost too much ground there. But you can see here the percent of births that where babies got the Hep B vaccine within 3 days of birth, again, varying greatly around the state. We're going to keep digging into this. Hepatitis B, I mentioned before, this is all from the cancer registry. This mapping feature, of course, has been linked to liver cancer, and we work really hard to try to prevent that in children. Okay, that's it. All I have for my prepared slides, and it looks like we have 9 minutes for questions. Thank you very much.
Thank you so much, Dr. Hahn. I have got a couple questions in the chat that I'll get started with, but again, feel free to drop anything else in the chat or raise your hand if you have another question. So first of all, I know that you covered some of the decreases in immunization rates that we've seen, but are there any vaccine preventable disease increases that we've seen due to those lower immunization rates, or do you think that's to be seen, or kind of anything about that?
Yeah, that's a great question. You know, we really haven't, and I think it's because a couple things. The most common vaccine preventable diseases that we see, we have enough numbers to really look at trends. Some of them I couldn't speak to. Really, we have so few measles cases, mumps cases, et cetera, that at least in Idaho, we can't really compare. But we have not seen those kinds of outbreaks. Of course, we're worried about that, especially measles. You look at the international data, and the concern is especially about measles outbreaks. And now with the war in Ukraine, you get disruption of vaccination followed by disruption of people and health services, and there's a setup for these kind of outbreaks. Influenza, we actually saw that decrease. We think because of the reasons I mentioned earlier, but we are worried about future outbreaks if we don't find those kids that miss their vaccinations. So I will probably continue to mention this every year when I give a presentation, like if we're starting to see any increases that we think could be attributable to under vaccination, but that has not been manifest yet.
Okay, we will cross our fingers and get working on catch-up. This question says, can you explain more about why Pfizer for 6 months through 5 years was postponed?
Yeah, I'll try to do the best I can. And there may be folks in the immunization program, they also get information on this directly, sometimes from their partners. Here's my understanding. There was a lot of concern that if we were to see another surge, that those unprotected kids would be at greater risk than even partial protection. So the effort by the FDA, my understanding was the FDA actually asked the company if they could send them their data, even though the companies were still in the middle of studying a potential 3-dose series. They said, I know you've only gotten to the point where you've got 2 doses in those kids, but you've got the safety data on those 2 doses. You've got some early efficacy data. Can we just look at that and maybe even say, hey, parents, you might want to get your kids these 2 doses. We know it's safe. It appears to work, and meaning we're getting good antibody responses. I think there's a little pressure, to my understanding, to try to get some information to parents and something out there for them, some option. And I don't know why that didn't move forward, but I suspect that many people reacted similar to how I think many of you all listening, and I myself was like, I don't know that that's a good idea. We have parents of very young children. Absolutely, they want their kids protected from COVID, but number one, they want to make sure that anything they give their kids has been studied and has been reviewed thoroughly by the FDA and has been found to be safe and effective. And I think FDA just realized that the sentiment was not to support kind of appearing to rush out something that was not kind of half-baked. That's my understanding of what happened. I was very surprised to hear they were considering doing sort of this premature or early rolling out of the 2 doses, but that's just my impression.
Okay, thank you. We've got another question here in the chat that says the COVID vaccine rates are high in the upper north states and the disease rates are the highest there as well. Can you explain the correlation?
Yep, that's a great question. I knew somebody would ask me that because, it's funny. Here we've had 2 years of this now, right? And the vaccine disease rates have gone up and down. They've gone up and down in different states at different times. They've gone, we have outbreaks at various parts. Meanwhile, vaccine rates have slowly been trudging upward, but at very different rates in different states. Understanding why the things are happening that they're happening, I think we don't understand. So everything we do is speculation. With the virus, sometimes I feel like it's it's just doing its thing, and we aren't really able to understand why things are going up and down. It is possible. First of all, remember that herd immunity has not been well defined for COVID. Some of you may remember. I think the first number I ever heard about that for COVID was 70% vaccinated, we're good. 70%, we've got herd immunity. And then it started inching. Every time I heard an interview from Dr. Fauci or anybody else, it was inching up. Next thing you're hearing 80, and then you heard 85. I think now we are realizing that we are unlikely to really have herd immunity effect from the vaccine, the way the way the virus is behaving, because it's changing so fast that even if you have a fairly high level of vaccination, let's say over 80% like we have in the Northeast, you have new variants coming along that don't seem to care as much that you're vaccinated because they're shifted just enough or drifted away. And also you have people that might have had natural immunity from being infected, but now that is going to wear off. Both of those are wearing off. So all those things are happening at once. The Northeast East right now is seeing this bump, but we're not seeing it in the West. Some people are saying, well, maybe that, even though the majority of our cases are that BA2, that new subvariant, and some people are saying, well, maybe it's because you all got Omicron, because you weren't vaccinated. The Omicron version 1, washed right over your population, and now you guys are sitting pretty. You're all immune, whether it's because you recently got your booster or whether it's because you just had Omicron a few months ago. Maybe we are in a short, happy little moment of relative herd immunity because it's not like we all got Delta. It's not like we all got an earlier variant. Many of us, some estimates are more than half the U.S. population got Omicron. Maybe because of our lower vaccination rates, we all got Omicron, and so we're going to be relatively, quote unquote, protected from this BA2. But everything I'm telling you guys, I will acknowledge is guessing, speculation. different opinions, but I totally agree with you. I had that same thought. I thought, wow, kind of ironic that I'm going to show you two slides. One is going to show you this big, this increase appearing to happen in the Northeast, and the other one is going to show you that they have the highest vaccination rates. Now, that said, I will say that what you guys know isn't the case numbers. It's going to be their hospitalization numbers and their death numbers. And so far, at least, I've seen only small increases in the hospitalization rates, not big surges. In a few weeks, we'll know a lot more about what's going on and whether the Northeast really gets hit hard or whether they just see a little surge in cases that doesn't result in much.
All right.
I'll leave it at that. So,
short answer.
Great question.
Short answer, not really, but we have a lot of ideas and more information to come.
That's right.
Okay, all right. Well, that is all the questions I see. I don't believe there were any hands raised. Megan, can you confirm?
Hi, Marin. I do see one hand raised. Leslie, if you still have a question, feel free to unmute yourself and then remove your hand and mute yourself once your question is asked. I guess I want to confirm, Leslie, do you still have a question? I see your hand is raised. If you don't, go ahead and remove your raised hand.
Well, let's just, oh, okay. I think the hand
is gone.
I don't know. Well, I think either way, I think we're right about out of time. So Leslie, if you can hear us and you do still have a question, please feel free to email me and we'll make sure that question gets answered for you. Thank you again, Dr. Hahn, for your time. Thanks everyone for joining us, and we hope to see you for the rest of our sessions this week.
Thank you all.
All right, thanks. Bye.
Bye-bye.